Hi, everyone.
Oh, hi, Boo Boo. How are you?
Good. How are you?
Good, thank you. Hi, everybody.
Good afternoon, everyone.
Good
Good afternoon.
afternoon.
Good afternoon. Senator Armour will be a little late, and he's asking that we go ahead and start the meeting when you're ready.
Okay, thank you.
Sounds
You're
good.
welcome.
So perhaps I'll defer to Representative Ahi to let us know when she would like to start. Hello.
Everyone. I will say that I will be here listening in and providing support, but I fully support the two of you taking on the lead and going forward as you see fit. I think it's okay to get started without Senator Anwar. He will join as he's able, which will probably be very shortly. But it's wonderful to see all of you here and appreciate you taking the lead.
Okay, wonderful. Well, thank you. So if that's okay with everybody, why don't we start? I know the first agenda item is convene meeting. I'm not sure if anything else is needed administratively except to say that we're starting. That's it, right? Okay, excellent. So for the second item, what I thought I just wanted to place is that at the first meeting, we had a general discussion about fatty liver disease, and I know we're all here with our own particular expertise. So I just thought at least provide the opportunity if anybody wanted to bring up any general points about the disease condition. And I say this because, this disease does have many aspects. There's obviously the biology of it, what's going on inside the liver, but there are social aspects, nutritional aspects, behavioral aspects. So and we have experts on many of these. So just if anybody would like to either give their own perspective or if they had questions, I just wanted to make a little bit of space for that. No. Okay, no, that's fine. That's fine. I just wanted to. Now, hopefully you've all had a chance to look at the 9 points that were presented to us as discussion points. What I have done is actually just group them into 4 categories, which seemed fairly natural. Peter, I'm not sure if it's possible to just put those up on the screen rather than me having to sort of read them out. Would that be possible?
Yeah, you can share your screen if you'd like.
Oh, you want me? Oh, okay, I can. Okay, 1 second. Let me activate them. Then I wasn't expecting that. So just 1 second. Okay. Okay. Can everybody see this Word document?
No, not yet.
How about now?
Can you guys see?
Yes, I can.
Oh, you can't? Okay, maybe I can't see it. Let's see. I may need to change my settings.
Did anything change in your screens, or is it just the same?
I can see it now.
You can. Okay. Can anybody not see it? Okay. I think we're okay. I mean, these are just the same 9 points that were, sent to us originally. And what I've just done is I've just sort of, grouped them because I think it's for discussion purposes, obviously, if we can discuss similar points at the same time. So I'll just briefly go through the groupings. I've kept the numbers the same as in the original state document to reduce confusion. So one natural grouping is essentially population data. This is simply, looking at the information that we actually have about the disease. And this heading contains these 2 points, which is the incidence of the disease in our state compared to the rest of the country, and then the populations most affected at risk and being diagnosed. The second are policy and other interventions. So this would be actually something that we would initiate or enact. And this has three individual components, strategies for preventing the disease in high-risk populations, policy changes to improved care and outcome, and then the manner in which social determinants and health influence the risk of the disease. I won't read them all out because obviously they're in front of you. And the third is, I've headlined this, creating structures to increase awareness and detection. And this has three of the original subheadings. So one is methods for increasing public awareness. Second is implementation of statewide screening programs. And the third is the creation of patient advocacy and other support networks. And then the final category, which is on its own, is therapy. And there is sort of the generic issue of insurance coverage and affordability. So 2 points really. One is whether everybody is comfortable with sort of grouping these, because I thought going through 9 individually would be actually kind of tedious, and it made sense for me to group it. But we can either not group them or we can group them differently if people would like to do that.
I think the grouping works to sort of think through similar questions at a time, as opposed to going back and forth.
Okay, yeah, because the way they were listed from 1 to 9, the most similar ones were not always next to each other. There were different things next to each other. Okay, then the next thing I wanted to do is ask the group if we wish to add any topics to this. I mean, to me, these 9 are actually a pretty comprehensive set of topics, but obviously, we have the ability to add topics to this if we should wish.
Watch, are you able to maybe, I mean, I know that the font is small, but maybe just put everything on that.
Yeah, sure. No, of course, I can zoom out.
Yes, perfect. Thank you.
And I was impressed. I think it's a very comprehensive list of topics. But again, folks on the call have their own expertise. They may wish to bring up areas that are sort of particularly important to them. But I see determinants of social determinants of health. I see advocacy. I see collecting population data. So it seems like a pretty comprehensive list. And again, even if we don't raise any additional points right now, we can always come back to it. I just wanted to give us some time just to see if we wish to raise any additional points. It's not as if the door is going to be shut to this once we move on from this agenda item, but okay. So perhaps keep thinking about that. But maybe we could make a start. We certainly have plenty to discuss and look at. So maybe we can make a start. But in the meantime, either just at the next meeting, if you think of any additional points in the interim, you could email myself and Peter if you have any additional points. Okay. So while we're doing that, I think for today, the other thing was to really, obviously start discussing one of these, and at the same time, briefly look at our available timetable and see how much time we have to do various things. So for example, maybe if I could just briefly jump onto this. So, these are, if we meet every 2 weeks, these are our future meeting dates. So after today, we have potentially 5 meetings. And frankly, that's a lot of work to be done, because if we have 4 discussion points, we could discuss 1 today, 2nd, 3rd, 4th, which would be, so by November 20th, we would have discussed the 4th point, and it would basically give us just about a month to actually put something down in writing, which, considering we're all busy people, is actually not that much time to write and then circulate and review and come to an agreement. So in terms of moving forward, if we could, what I would suggest is we discuss the first point today, then the second point on the 23rd, then the third, first topic today, second topic on the 23rd, third topic on November 6th, fourth topic on November 20th. And by that time, at least begin to think about writing our recommendations down. Would that be okay?
So watch with the 4 groupings that you have, I guess we can see what everyone thinks, but is it felt that we do need to discuss all 4 topics, or do people feel like focusing on?
Well, we were mandated the 9 topics, right? I mean, that was actually in the document. So I don't, even if we're allowed to ignore some, I mean, I think since that was given to the committee, I don't think we should ignore any of them. I think we should at least discuss some of
all of them.
All of them. I'm not sure they can force us to discuss anything, but I think we should still discuss all of them.
Mm-hmm. Well, the 4th one is just 1 point. Is it possible maybe to add that to another, so that instead of having 4 different
we could see, if we get to the 3rd topic and we're going like gangbusters, we can always just get to the last one at the same time. So yeah, this is just a rough idea. Okay. Well, we have a lot of work to do, so perhaps we could just jump into the first topic, which is population data. So I'll just zoom into that, since I want to make sure the font is enough for everybody to read, and maybe just take a few seconds just to make sure everybody, has read these 2 topics. Okay, so for the first one, Dr. Benini and I did a little bit of background work, which is basically to identify what do we know about the incidence of fatty liver disease in the state of Connecticut and nationally. And the answer is pretty grim, actually. What I mean by that is the publications that are out there have been looking at insurance databases. So, they'll go into, obviously we know what insurance databases is. So they'll go into these insurance databases and see how many of the claims had fatty liver disease as a diagnosis. Okay. So there are several problems with this. One huge problem is that, first of all, we'll only identify cases that are actually diagnosed as fatty liver disease and then coded as fatty liver disease. Okay, so obviously, clearly, if a disease is not being recognized and is not being diagnosed, it just won't show up in these databases. That's one huge problem with these databases. And the second huge problem is that these databases almost entirely exclude Medicaid population. And also, by definition, they exclude anybody who's not insured, right? Because these are insurance databases, right? So these databases are really full of individuals who have private insurance, and about 30% of them are individuals who have Medicare. So there's a huge chunk of our population, primarily the uninsured and the individuals with Medicaid, who just don't even show up on these databases. So these are 2 big problems. The folks who are not diagnosed don't show up. So if someone's just sitting at home with a disease and hasn't gone to a doctor, they just are invisible. And then similarly, even if they have gone to the doctor but don't have insurance or Medicaid, they're invisible. So essentially, I think, I won't say these databases are useless, but huge gaps. So I just wanted to put that out there and see what folks thought about that. This is still the first point.
Just quick question. How were you able to find this data about the fact that Medicaid does not include these diseases in their databases? I don't know anything about this. I just want to know why is it not included? That makes no sense to me.
No, I'm not saying it's not included. So these were publications that essentially went into insurance companies' databases and extracted data. So these insurance companies basically had data on the privately insured and the Medicare populations. Why they don't have data on the Medicaid populations, I don't know. Okay. My area of expertise is more sort of biological research. My personal expertise isn't in, pulling population data, and I can look into it, but nonetheless, that's what the publications show. So,
I see.
which really, I mean, and particularly if we're dealing with the disease, that is, we already know is overrepresentative, in the patients who are uninsured and maybe on particularly likely to be on Medicaid. It's just, I mean, even without that, this would be a problem. But considering that this disease is a disease that's overrepresented in these populations, it's just a huge problem, basically. So I think we do need to come up with some suggestions how to fix that, because we just don't know what the incidence of the disease, for example, is in the Hispanic population in Bridgeport. I mean, to make it a bit concrete, shall we say. And then the
I could
second,
make one point. So this is Jorge, by the way. I don't know
hi,
if
Jorge.
hey, sorry, my internet's a little wonky in the clinic, but the my thought about that is oftentimes what I've noticed in my patients' charts is that the imaging has been done that was incidentally noting fatty liver disease, but there was no follow-up to that notice. There was no like flagging of that notice. So, and I don't know the logistics of this, but one thing that happens, for example, with breast cancer screening is that the patient actually gets a letter that says they have dense breast or they have this or they have that. So one thought I had is maybe we kind of have to go through, we're kind of missing a lot of this, right? And
Oh, yeah, for
maybe
sure. Yeah.
and so, but there's a lot of imaging out there that has been done and has shown fatty or the signs of fatty liver disease. So maybe we need to flag it in the radiology report in a way that tells the patient and the doctor that this should be followed up on. Maybe not confirm the diagnosis because there's more to that, but at least flag it. So similar to breast cancer screening. So then that's just kind of off the whim. I had just, thinking about how to catch this because I just had a patient that had signs of fatty liver disease that were just not flagged from an imaging that was done previously. So anyway, just a thought.
No, that's exactly right. As I said, that we have two big problems. One is simply lack of formal diagnosis. And the second is that we don't have data on big chunks of the population, probably about 30% of the population. So what you're speaking to is obviously where the raw data is present somewhere in the system, maybe an ultrasound to make it clear, right? I mean, that's the most common reason. Someone had an ultrasound because they had some abdominal pain. The ultrasound shows, high degree of steatosis. And then it just doesn't go anywhere. It just sits there in their chart and a formal diagnosis is not made, basically. So that's exactly right. So, there of course, there are ways to, collect that data and simply, even if we were to ask the question, what percentage of all ultrasounds that are done in the state of Connecticut show steatosis? Irrespective of whether someone's insured or not insured. Now, of course, that would help with the diagnosis aspect of things, but it won't really help with the uninsured because, of course, people who are not insured are much less likely to even get the ultrasound. But I absolutely agree. I think that's an excellent idea. I mean, that would require obviously some sort of a electronic database search algorithm or protocol or something like that.
Yeah, I totally think that's a good idea. That would be a good place to start, and will provide a lot more data than what we have now. Not ideal, but definitely much more improvement in terms of getting a sense of, how many might have the disease. And I see, Jorge, that would really fit nicely into maybe one of the policy changes in the second group of topics, number 6, right? So if there was a policy or some kind of guideline that said if the liver seems to have steatosis, it needs to be flagged. And then that will then lead to people paying attention to that.
Right.
I think just to follow up on that point, I think agreed. I don't think we have enough data going backwards, but I think if we're setting potentially the state is setting new policies going forward, we can have that be created as a flag exactly for the future, so that now we're flagging all the new CAT scans or ultrasounds that are done in the state that show signs of steatosis, so that it can be because some of the time it's not even in the impression, right? it's only in the body of the report. You have to go
Right.
find it to really like track it down. So that change could be it reminds me so closely to what happened with breast cancer screening, because we had that issue with dense breast, and now here we are, and now every single patient gets a letter of their results no matter what. And so I think that if it could be using almost as a model going forward, it could be very helpful to catch these diagnoses quicker.
No, that's tremendous. And especially being prospective, I think, adds a certain rigor to the data set that we all know. Retrospective data sets are always open to all kinds of biases and such like. No, I think that's fantastic. No, so I mean, we've immediately, obviously, very quickly slided from a discussion to actually discussing recommendations we might make. So it's my first working group for the state, and there obviously recommendations can come in all kinds of flavors and scales and all the rest of it. So I had asked Peter, and he'd very kindly shared one previous workshop report that had been prepared. It's a very long report, but what I wanted to do is I'd like to share just the first recommendation on that report, just to give everybody an idea in case other folks also have not been on such a working group. And then also, before I do that, just sort of give my bias, which is to say that I think any recommendation that we come up with, I would like it to be, if enacted, to be impactful. It's tempting to give, shall we say, small recommendations or easy recommendations, because we all know that, obviously challenging recommendations we know, are going to be challenging, right? But I think, I personally wouldn't, and you can all decide for yourselves, but I'd like to sort of, come up with recommendations, which I'm not saying they're moonshots, but at least they should at least be impactful. And if they're challenging, we can discuss if they're too challenging or not. But I'm just going to switch to so this is, and I'm just going to, so this was a task where you can read. So this was a task force for to study provisions of behavioral health in young adults. Okay, so fine. Okay, but the first recommendation is, and you can read for yourself. And frankly, I was surprised by this because it's just almost, to me, a moonshot, right? I mean, basically, first it's mandating primary care providers, and then requiring screening in a huge age range, 0 to 25, in all of Connecticut. Okay, so this is very substantial. So I'm not saying that we ask for expansive things just for the sake of them, but at least it gives me an idea that we shouldn't shy away from recommending, or in this case mandating, items that we really feel will be impactful. So going back to our own task, so I mean, I absolutely agree with the recommendation that was just made. The other approach to this is, whether we can go into populations that we know are underserved, underrepresented, but we know have a high incidence of disease, and actively collect information. Because again, if we wait for incidental imaging, which we can do as well, then again, there'll be significant proportion of people who will just never get the relevant test. So what are folks' thoughts about that? So we can't screen everybody in Connecticut for fatty liver, but perhaps we could go into certain areas in certain cities.
I mean, if you're looking at uninsured, could you go to particular community health centers in more densely populated areas and offer that data to be collected?
Exactly. So, and exactly what modality of screening we could discuss, but just exactly what you said, Alison.
And I also think of pockets of populations, whether race or ethnic based. For instance, one that comes to mind is a Native American population, who we know have a pretty high incidence of fatty liver disease. So that may be another place to see if we can get some data on that population.
I'm really happy you bring that up. I have a really high population of patients within that category, and I think it's something that we really miss a lot. So I'm happy you bring that up, Dr. Bonini.
Right. Thanks.
Yeah, so the two populations would be the Hispanic and Native American, I think. And obviously the numbers are much greater in the Hispanic population. This, you know, we could discuss, if it sounds like folks are generally in agreement with that, I mean, we could pick certain geographical areas where, you know, we'd expect the high-risk populations to be. And then, you know, if people are in agreement with the principle, then we would need to discuss exactly how we're planning to screen this population. I mean, not screen, but offer screening, right? That's all we're doing. We're offering screening.
Can I just, this is Elizabeth Conklin. I'm here representing DPH and I'm new. I just want to introduce myself real quick and then add some comment to the discussion. I'm the supervisor of the Heart, Diabetes, and Brain Health Unit here, which is working predominantly with high-risk populations and FQHCs. And so I'm here to talk, not as a subject matter expert, but also talk about some of the outreach and marketing thoughts. But I wanted to add on about the available data that DSS, our agency, Connecticut DSS, houses all the Medicaid data because they provide that. So I feel like if you really want to get accurate data what the incidence is, we could reach out to their leaders and say, hey, pull us what we have as a baseline. I know it's not comprehensive, as you said, the uninsured, but at least it's a starting point. If you want to show like you're making an impact with screening, you have to have a baseline to start with. So I would say that would be a good contact, not to necessarily build into this group, but to be able to get something, as a starting point of what we have for the Medicaid population of diagnosis.
Oh, no, thank you. That's fantastic. Now, do you see that essentially being a recommendation for this working group or something that these colleagues might be able to provide us, say, within the next 1 or 2 months so that we could actually use the information?
I think we could definitely get some of the information from them. I have a contact that I use for my program for diabetes rates and heart disease out of the Medicaid population. So I certainly could reach out and say,
okay, fantastic. No, that would be even better. Yeah. I mean, if we could even get that information before the working group wraps up, that would be fantastic.
I can't make any promises.
No, I know.
It's a data poll and,
yeah.
but no, I'd be willing to have
yeah, if not, then we'll just have that as a recommendation for something that we should do after we wrap up. Okay. Tremendous. So going back to the topic of screening high-risk groups, it sounds like we have a general agreement that in principle, that's a good idea. Obviously, in terms of how we do it becomes a little bit of a subject matter, knowledge-based type of a thing. And we could either discuss that now, or those amongst us, who are familiar with screening for fatty liver disease could discuss it afterwards and report back to the committee, whichever we prefer. I mean, the two basic modalities would be either some blood test-based screening or some sort of imaging type screening. Those are the two big modalities. Or, of course, both.
I would say both, ideally, but if not both, then at least one of those.
Yeah. And, my inclination would be to lean towards the imaging type because, it's on site. You only have to make contact with the patient once, and it's done. And you have the information.
Right.
Whereas, the blood test, of course, the patient has to go get the test. You have to track down the data, et cetera, et cetera. So, okay. Anything additional on that point of going to high-risk populations? I mean, I would need everybody's help to identify where we might expect. And by this, I mean, like, individual clinics that we might recommend in various parts of Connecticut that might have a high-risk population, say a Hispanic enriched population.
Are you asking to screen all Hispanic? As I said, I'm not a subject matter expert, but I do work with at-risk populations based on my CDC grants, and that's obviously a priority, including addressing social determinants of health and barriers kind of align with a lot of this work, which is great. So I'm really happy to be at the table. Is your goal to screen everyone that is Hispanic, understanding that's the most high risk, or because it's a big net to cast if you're looking to start at a starting point? Is
Yeah.
it FQHCs?
No, for sure, for sure. No, so I think that's an important point. So obviously, to get data on the incidence of fatty liver in the Hispanic population, we wouldn't need to screen everybody. We'd obviously could go to, certain areas and decide how many people we would need to screen to get that sort of information. And that really was the first point, is to have the incidence of this disease. Again, I mean, the reason I had put the recommendations for the other committee is that, that committee at least came up with not even recommendations, they used the word mandate to screen everybody in Connecticut under the age of 25 for behavioral health issues, which, frankly, I was surprised by, because it's just such a broad task, and is worded as a mandate, not as a recommendation. But I put that up there because it seems like these working groups actually have quite a lot of reach in terms of what they wish to do. But in terms of identifying the incidents, I wasn't thinking of screening everybody in the state. I was thinking of, identifying particular sites, maybe 4 or 5 sites, and then getting data from there. But I'm open. I mean, I'm open to all suggestions by folks. I mean, if people feel strongly that, we want to use language like mandate screening for fatty liver disease in all Hispanics in Connecticut, I would not push back.
I think in terms of logistics and time, it might be more practical to pick representative populations and then use that data to generalize, which, is commonly done sort of in biostatistical studies. In terms of the language they use for mandate, I want to say it parallels sort of what Jorge was saying, that developing policies that will increase the diagnosis and intervention for these groups. So I can see how we can use that mandate as in mandate flagging of studies with showing fatty liver disease. So I think it depends on what it is. So, and that example you showed, I think, was out of their initial studies that they said is important enough to mandate the screening of every single person, because if you don't screen, you will not diagnose.
Right. No, you raise important points. I mean, there are two very different things as far as I can see that we're speaking about. One is essentially data collection, right? To get data on what the actual incidence of the disease in the Hispanic population is, because we just don't know. And that essentially would come under the guidelines of a study. Whether it's a 1-year study or a 4-year study, we can discuss. The separate issue in terms of having ongoing screening is not a study. I mean, it's just ongoing screening, basically. And, whether that's based on what Jorge said in terms of just ongoing conversion of raw imaging data to a diagnosis or ongoing screening, so these are two completely separate tasks, shall we say. Okay, so maybe we could, and again, and the reason I was surprised but also kind of pleased by that first guideline is that I just want to make sure we don't undershoot. It's the first time I've been on this working group, but it appears like these working groups have, I mean, we have no power, right? I mean, these are just recommendations, basically, but it seems like that, we do have leeway to, really recommend extremely broad changes. I mean, they may not go anywhere. I mean, we can mandate whatever we like, but nothing may happen. But it's not as though, it's outside of our remit to come up with some broad suggestions. So I just want to make sure we don't undershoot because we think it's, oh, well, that's just too much, shall we say. So
I think Representative Vahey had something to say.
Yes, I'm sorry. Yes.
Hi, Rep. McCarthy-Vahey here, and thank you for this conversation. As I listen in, I would just say that we as the committee leadership who will take these recommendations, we would work with the Department of Public Health and we would work with those organizations and agencies. So in as much as you have you bring knowledge and awareness of those agencies and experiences and understand the complexity and difficulty of something like the kind of broad mandate, Dr. Nahal, that you're talking about that was recommended, which are very difficult to pass, as you understand. So I think the thing we talked about a little bit before was having the broad vision in view and the moonshot. There's nothing wrong with that. And then looking at how that breaks down, that might break down in pieces for how we might move there. So if I would just suggest, when you think about those moonshot visions, if you would also be thinking about a pathway for us to move in that direction. And that kind of thinking, I think, helps us to be more successful. I think for better or for worse, as legislatures and legislators both, we tend to make more incremental progress on many things. And every once in a while, we make bigger progress on a few things. So I don't know if that's a helpful frame or not, but certainly in the end, I want to concur with what you're saying. It's up to you as a group what you choose to recommend based on your wisdom, knowledge, and experience. And that's why all of you are here.
Thank you so much. It's extremely helpful. Okay. So maybe, we can think of some of these recommendations as more as vision statements and others as concrete statements, which hopefully will turn into reality. Okay. Okay, so we have, I would say in terms of concrete statements, we have two. We have Jorge's suggestion, which is essentially converting data that's already acquired into diagnoses. And the second is actually going into a selected group of high-risk populations and actually generating new data to try and identify, what the incidence of fatty liver disease is in a high-risk population. The second part, which is, you can read the population groups most affected at risk of being diagnosed and the main risk factors contributing to prevalence in such groups. That second topic could be rolled into going into the communities and obtaining data, because obviously we could obtain data about, nutrition and all the other sort of risk factors that we believe are involved, but we don't necessarily know how important a particular one is, So what's the relative importance of lack of exercise versus a poor diet? Both we agree are important, but nobody really knows the relative importance of these two. So is there a third recommendation anybody would like to come up with, apart from, in addition to Jorge's and going into high-risk communities?
If you're going to be having the individuals in the communities already have the imaging done, would you just have them do a questionnaire about their habits, their lifestyle habits?
Absolutely. No, absolutely. No, absolutely. That would sort of bring in number two. And again, I am uncertain, because we also know genetics are important in this, right? And there are about 5 different genes that we know are important in this area. So do we want to take that step as well, which is to collect a sample and see, because just because someone has this label of Hispanic, we know is a very, inaccurate sort of a label. And underneath that, if we could identify particular genetic drivers, that would be extremely useful.
I see this also as an opportunity to, even beyond these specific recommendations, set ourselves up for questions that may come after that, like you're saying. So, for instance, if we're going out into the community to do screening, ideally would have an imaging modality like FibroScan available. We should be able to ideally be set up to collect blood samples maybe as a screening for their liver chemistries, but potentially also biobanking, right? Those are separate conversations, but if in an ideal world, it would be good to be able to do that as well.
Right. So, the scope of the screening is something that I think just deserves discussion, and I'm not sure how broad we should make it. I mean, the most minimum scope would be to go and simply do something like an ultrasound in a high-risk population in, say, 400 or 500 patients a week, and then just get data on fatty liver, on steatosis, and that's it. That's all we do. But obviously, it could be expanded to questionnaires. It could be expanded to making a formal diagnosis, which would require ruling out hepatitis C, for example. I mean, I can obviously think of a very expanded pilot project or outreach project, but since I'm just wondering where we should draw the line for something like this, and obviously practicalities come into it in terms of what the budget might be and duration, et cetera, et cetera.
Not to put Elizabeth Conklin on the spot, but my sense was that you may have been in other working groups that may have sort of asked those questions. So for instance, your study with diabetes, high blood pressure, that those kind of things come up in terms of the scope or the scale of collection.
This is actually my first working group, so
okay.
I'm a novice, but I've been working with at-risk populations most of my professional career as an MPH and working at DPH 10 years now. So not to overstep my bounds, because I'm definitely not well versed in this disease as much as I should be in terms of diagnosis. So I'm really learning, but I think screening is universal for a lot of the diseases that I work with, diabetes and heart disease and things. I think what I'm hearing, pilot seems like a reasonable starting spot, because it's hard to make a recommendation that every Hispanic or even
of course
SQHCs do screening. Like, I'm not sure what this screening would entail, in practicality. Is it better to start small and then try to make recommendations to move forward? So I have not been part of any recommendations. I'm listening, kind of taking it all in, but I can see that there is definitely there will be some practicality challenges.
Right.
Right. I mean, if we look at the second point on that list, which is not just screening, but to identify the main risk factors contributing, then, simply doing the ultrasound and identifying what percentage of the population has fatty liver obviously won't provide us with the risk factors that are contributing. We'd have to extract some additional information, whether it's nutritional or blood-based tests or something. So I think if we're going to address the second point, which we have to, because we were given these 9 points to address, then it'll have to be more than just screening. We'll have to collect some additional information. And what I would suggest is that we propose to, collect, sort of questionnaire type information, but also blood samples. And then it may get curtailed to only questionnaires, but that's something that can happen down the line. But we have been asked to address this issue of identifying the main risk factors, and there's just no way we can identify the main risk factors without collecting some information.
Can I ask what the main? I know that it's not necessarily, Hispanics are higher at risk, and I've done some research to be prepared for this in terms of the topic. Is there one thing that stands out to you that helps you identify somebody? I know diabetes is not necessarily a diagnosis or a risk factor, but is there one thing if someone presented in your office that you'd be like, hey, I definitely want to test this person for this? Or is it kind of a cadre of things that could appear?
Well, the reality is it is a bit of a cadre, and about half a dozen to a dozen are the biggest contributors. If you had to pick one thing, waist circumference would probably be it.
Okay.
Because really, if you're only allowed one data point, really, truncal obesity would be that data point rather than even total weight.
Okay.
So,
thank you.
Okay.
I'm sorry. I just wanted to. This is Liz Richardson. Just wanted to make a point. I know we're talking about population and screening. It seems like more on ethnic factors, but also kind of following up on the last point of the other medical risk factors. I don't know. And again, I'm just thinking out loud. if this is also an opportunity to partner with some of the other working groups, because we also know that the prevalence is higher in folks with, for instance, diabetes. And so like focusing some of our screening efforts in a population that's known to also have increased risk of diabetes, which is also Hispanic. It all kind of goes together, but just kind of another
absolutely.
thought.
No, absolutely. Yeah, I know exactly. I mean, it should really be high risk populations, and those obviously, as you brought up, can be identified in several ways. So, so screening in a diabetes clinic would be an excellent way to hit a high risk population. Exactly. And then, maybe whoever is interested, obviously we can't do all the work during this meeting, and whoever's interested, we can, in between now and the next meeting, the next 2 weeks, we could actually come up with, say, a half a page or something like that, which would have some specifics as to how we would screen. But I don't look already as we're speaking. I think we are essentially going to need some form of imaging. We're going to need some form of questionnaire to get information that's not in the electronic medical record. We will want to access the electronic medical record, right? Because obviously patients might have whatever else, and then probably some blood tests. So those will be, I sort of see as the 4 sort of intake types that we have. Yes, Senator Anwar has his hand up.
Thank you so much. I am listening intently to this great conversation and so thankful for each and every one of you to bring your expertise. I wanted to think aloud with you guys about, from a legislative point of view, funding a study is a little tricky, but one of the hopes was that using the existing scientific data, what things can be implemented to change the trajectory of the high risk populations to get NASH. I think that's one of the ultimate goals that we can say, okay, we can do this and so on. Because if you do blood tests and other parts and it's a structured research, then the state may not be well equipped for that part to be able to do. But we are well equipped to be able to make policies that would help us change the trajectory in the high-risk population. So keep that in the back of your mind as we look at the various options of how to tackle this issue.
No, thank you. That's extremely helpful, because ultimately we don't want to be coming up with suggestions that don't turn into real reality. So thank you for that. So I mean, if turning back to what you've just highlighted, that would really, I think, move more towards what Elizabeth had been saying in terms of using data that's already in the Medicaid data set and identifying incidents on that. And then in terms of policy changes, which we're sort of moving a little bit ahead from here, which is really sort of the next group of things. I'm not sure if folks have in mind.
So for example, I'm just pulling this out of a hat just for the sake of a conversation. This may not even be relevant. That increasing educational opportunities about the disease in XYZ zip codes or the zip codes with such and such challenges. Talking to fast food facilities or convenience stores for changing the product lines because of their association with NASH in some communities. And so that could be some of the potential policy recommendations that would start to reduce that risk from actual area in the community where the disease starts to happen. And perhaps, again, increasing advertisements in various languages so that through radio or television or through targeted messaging through social media for specific high-risk communities. So those kind of recommendations
Sure. Thank you.
Something to consider.
Yeah, no, that's great. And again, I mean, that does spill into the next session, but that's fine. It's on the screen at the moment, so I think that's extremely helpful. I'm struggling still a little bit about how these policy suggestions would help us with the first 2 points, which is to identify the incidence of the disease in the state, and also identify, main risk factors for the disease. So, I mean, as far as the incidence goes, we said, right at the beginning, all the information we have are from analysis of insurance databases, which basically contain privately insured and also Medicare patients. So there are huge gaps in these insurance databases. So I'm just sort of struggling as to how to get to the true incidence of the disease, particularly in the Hispanic population and in the uninsured population. That's what I'm struggling with at the moment.
I wonder if extrapolation would be the way to look at it, but that's the part. It's looking at the existing data and then seeing how we can create that. Otherwise, doing an incidence study for the state or through the legislative branch is going to be tricky to
get through.
But I do want to.
Good idea though to have it on a list so that we can work with UConn or perhaps other institutions. Sorry.
So I do want to add though that even if we were to look at the currently available databases, we know grossly underestimate the disease incident. I mean, there's been like NHANES databases, and if you analyze NHANES databases, it tells you about 10% of the US has fatty liver, but we know that that's very, very low. So we kind of have to rethink how we are going to get this data, because unfortunately the available databases are not reliable. Definitely, to your point about cost and logistics, we have to think of how most practically we can get this, but I think it would be hard to rely on the currently.
So I mean, I think if we rely simply on the ICD codes that have already been coded, we know that it's going to miss an awful lot. So that's essentially the problem. Okay, well, maybe we can we can do both. Obviously, of course we will do what Senator Onward just suggested, but then we can also perhaps at least begin to put together what collecting new data might look like. It doesn't have to be one recommendation or the other. We can recommend several things.
I can just add one more thing. I think your point earlier, and then what Representative McCarthy also said, was that you do what you feel is the right thing to do and then make the recommendations. And perhaps what we can do is to start to see if there are ways for us to promote state facilities or other state entities to see if there's funding that can be provided or can be helped in some ways to make a priority in some respects. So those are things that can happen, but I can tell you practically, we may not be able to require a study, but I think we can advocate for some other things to happen. So all the recommendations that you feel intellectually as a collective body will be of great value to us. But we want, in the end, something tangible that we can actually do as well. Both things.
Great. No, thank you so much. That's extremely useful advice, because I think all of us, certainly most of us, this is the first working group we've been on. So we're driving a little bit blind down this road. So thank you so much. Okay. So, the first heading of population data with the first 2 points, I think we have covered that unless somebody wishes to come up with any additional things.
I do have a thought that it's not it might be part of a recommendation, is really to connect. I mean, as I said, Husky, which is the Medicaid population, would have the most up-to-date data. It would be something that I can't necessarily guarantee that we could get for this work group, but the recommendation could be that we reach out to them, find a way to get the most recent data, and then they can look at communities, or in terms of overall what's the rates, and then the communities most affected. Then you can figure out your next steps. But I think
that's fantastic.
You got to have a starting point,
right?
That's fantastic. Data, your Husky data, so that could be one of the recommendations to get
Thank you
accurate,
so much.
up to date.
Yeah. Could you perhaps tell us a little bit? So these are your colleagues in the state. These are state employees or academics in various institutions. Who are these people?
Oh, they are the people that oversee the Medicaid program, Husky Medicaid, at the Department of Social Services. So
at state level.
At state level.
At state level.
They also oversee, they know the numbers of diabetes diagnosis. So if you were going to overlap data, say, hey,
Mhm.
this is what we have for diabetes, this is what we have for NASH diagnosis, you could at least have a better picture of what the state has.
Mhm.
We like to have a starting point, at least from my experience.
No,
Like
of course, of course.
just
Yeah.
put the money and effort into.
No, of course. Okay, fantastic. Well, I'm keeping a mental track of um, trying to keep a mental track of all the points that have come up. Hopefully Peter is as well. So, okay. So I think unless somebody has any additional points, I think we have discussed the first 2 points on the screen that's there. And then and please jump in if there's anything else that you want to bring up.
I wanted to add just one point, in this discussion about using Medicaid data. Usually you can formally do a data request to Department of Social Services or Public Health to request that data, and then we could stratify the data by communities, zip codes, racial groups. I just wanted to mention that. And also just thinking about the limitations, even though I think primary data would be best, both the kind of the medical screening and the questionnaire, because you can also capture those social determinants of health with the risk factors, but also looking at large data sets like NIH's All of Us data, which specifically is for minority groups. And this is a massive data set that reaches about 1 million people. So we could also stratify that to look at Connecticut specifically, and we would have those the high-risk racial groups like Hispanic groups, African Americans. So I just wanted to mention that data set, and the CDC has a few more that we might be able to look at as well.
No, that's fantastic. Thank you for that. Again, being sort of practically minded, the question that comes up is that it seems like the Husky data set that there are already, experts within the state who can essentially do the work because it's going to be work to do all of this. The items that you suggested, Professor Dawson, how do you see that practically being done? I mean, do you see this is something that would be done, in collaboration with the faculty at a university? Do you think this would be something that we would request a state employee to do? How do you see that being done?
I definitely think we can ask a state agency to do it, since a lot of times they have to do an annual statewide assessment. So a lot of this work may already be done. But I also think about if we looked at a community-based participatory research approach, there's already collaborations and relationships that universities have in some of these communities. Like at Southern, we have an organization called CARES, and they're boots on the ground doing research in high-risk areas. I think if we partner with organizations like that at nearby universities, it may save us from the labor because we simply don't have the time based on the dates we have for the working groups. So those are my thoughts.
Okay. And were you thinking this would be done during the working group, or this would be a recommendation that we would have to be done over the next, say, year?
I would say the next year.
Okay.
We could probably get it started, but I don't know if we can get through all of it. It depends. It depends on the data set, the code book, the way the question is asked, things of that nature.
Yeah, no, that's excellent. Again, being practical, usually what I find with these types of things is that there needs to be, one champion who is pushing things along, because, whether it's an academic colleague or, a colleague who's an employee of the state, ultimately it needs, one person who is just kind of keeping the focus and pushing things along. So we'd have to identify who that is, and maybe we could think about, who that might be as we move forward. Okay, so I'm tempted to say that the second heading, which we were planning for the next meeting, we leave to the next meeting. Although Senator Anwar's already made some very practical suggestions in terms of outreach and making sure that all the information is available, for example, in Spanish and ads and such like. So we've sort of spilt into that a little bit. But I think if we probably all need to think about those 3 points, that number 3, 6, and 9 a little bit before we jump into that discussion. Would that be okay to stop at this point for this meeting?
I think so. Yeah.
Okay. Okay. Any other business then for today?
I think this was a great meeting. We had a robust
I think
discussion.
it's a good start.
Yeah.
Yeah. So Peter, one thing I could ask you, I think you're on the call. I'm going to stop sharing so we can see everybody. In terms of minutes, is that something that you and I would put together and share? Because obviously, quite a few things were discussed. What's the normal process?
So normally I would write up a meeting summary of this meeting, and then I'd publish online, but
Okay.
I can send it to you for review and editing if you'd like.
That would be super helpful. And anybody else who would like this doesn't necessarily have to
I
be
can send it out to the committee as well, yeah.
Yeah, that'll be super
Okay.
helpful.
All right.
Okay, fantastic. And then actually, I guess the video is available as well, right? Because this is being recorded.
Yes, on YouTube and on CTN, yeah.
And it stays online for a while?
Mm-hmm.
Okay.
On YouTube, yeah. Mm-hmm, yeah.
Okay, so actually I didn't need to remember anything. That's fine. Okay. Okay, well, great. So if there's nothing else, then perhaps we can adjourn for today. Okay.